Good morning, everyone. Thank you for joining us.
Good
I'm
morning.
Morning.
Good morning. I'm very happy to be able to introduce Dr. Leon Meytin to all of you. Dr. Meytin is a movement disorder neurologist and an expert on Lewy body dementia. He's with Hartford HealthCare, and he's here today solely to help and answer any of the questions that you have. So it's a rare opportunity, and I'm really happy that he's here. I'll let him start introducing himself for a moment, and then we can take it from there. Dr. Meytin, thank you so much for being here.
Thank you very much, Norma. As Norma said, my name is Dr. Meytin. I am a movement disorder neurologist in Connecticut. I practice out of Bridgeport, Connecticut. And my specialty is movement disorders, which, includes Lewy body as one of them. And I have a special interest in Lewy body specifically. And so I do a lot of work with the Lewy body community. And so I thought this would be a good idea to come on and just do an open Q&A. I don't really have a particular topic in mind necessarily, um, although I can talk about anything anybody wants me to, but it was really just to see if anybody has questions or what questions they have. You have me at your disposal, so any questions that you felt like maybe you didn't want to ask your doctor or that you did ask, you didn't get an answer to, or an insufficient answer to, this is your time to ask anything Lewy body related. Before I get started, I just kind of want to know who we have on here. My assumption is there's probably a lot of caretakers on here. But just if we can really quickly just go through and just introduce yourselves, who you are, where you're coming from, region-wise, and if you're a caretaker patient, just so I kind of know the audience that I'm trying to help.
Yeah, thank you. So if everybody, I'll just call your names, and if you could just say where you are and if you're either a person living with Lewy body or caregiver, and then we can move quickly for everybody. Thank you. Daryl, how about you?
Yes, I'm the caretaker for my wife. I'm in the Villages, Florida.
Thank you. Jean B.
I'm caretaker for my husband, and I'm in Stowe, Ohio, which is near Akron.
Helen.
I'm in New Jersey, and I'm actually kind of none of the above. My sister has Lewy body, and she's currently in a care facility.
Great. Thank you. Terry.
I'm in Puerto Vallarta, caregiver for my husband, Jonathan, and I'm not sure if he has Lewy body.
First. Yes or no?
Yeah.
Okay.
Thank
It's
you.
on. There's your audio.
Okay. Travis,
Yes.
are you a person living with Lewy body?
Yes.
Okay, and where are you located?
Austin, Texas.
Okay, thank you. Um,
My
and
wife is.
Lee. Okay, thank you. Paul and Lee.
Why it's not showing you?
In New York City with my father.
Okay.
Body.
Great, thanks. Diane.
Hi, I'm in Connecticut, and Dr. Meytin is my husband's neurologist. I'm a caretaker, and I love him. He's wonderful.
Yes. Hillary, you're on mute.
I think Hill, you're still on mute.
Yeah. Hillary, I'll come back to you in a minute while you do that. Carol Hunter, we can't see you, but we'd like to, or we can hear you.
Hi, can you hear me?
Yes.
Oh, good. I'm a caregiver for my husband, and he has been diagnosed with Lewy body.
Okay, and where are you located?
Oh, I'm sorry. I'm in Tucson, Arizona.
All right, thank you. And Hillary?
Oh, there we go. I'm from a suburb of Chicago, Naperville, Illinois. My husband has been diagnosed with Lewy body.
Thank you. Kristen Moss, we can't see you, but we'd like to see you or hear you.
I promise to be seen soon, but my name is Chrisanne Moss. I'm living with Lewy body dementia. I am in Naperville, Illinois sometimes, but most of the time I'm in Grand Haven, Michigan.
Okay. Thank you, Chrisanne. Let me see, this just moved a little bit on my screen. Carol?
I'm so, oh, me? Oh,
Yes.
Carol Hunter? Oh, yes.
Yes. Did I
Um,
just call on you? No. My
oh,
screen
yes.
just moved. Okay, I'm sorry about that.
That's okay.
Okay. Mark? Mark, we can't see you, but hopefully we can hear you. No, Mark. Okay, I'm moving to C. Brewster.
Hi, Cynthia. I'm in New York City and I'm a caretaker for my husband, Clyde, who has Lewy body.
Thank you. Karen Handel. No, Karen. Okay. Steve. Steve trying to get off of mute. Not working. Okay, not yet. Helene. Okay. No. And Barb Perkins. You were just on already? No.
Yes, our audio wasn't
Oh, I
working.
know. Okay, it came back on. Is there anyone I didn't reach because my screen, Sylvia. Sylvia, sorry.
Hi, I'm Sylvia, and I'm a caregiver for my husband. Oh, I'm in Sacramento, California, and I'm a caregiver for my husband who was diagnosed with Lewy body about 3 years ago.
Thank you. And Jean, you just joined. Your person newly diagnosed, correct? And where are
Yes,
you
ma'am.
located?
I'm a caregiver for my husband
Oh, okay. And where are
in
you?
Chapel Hill, North Carolina.
Okay. Thank you, everyone. It's important to know from people all over the country.
Yeah,
Okay.
this is actually, there's only one person from Connecticut and maybe a couple from New York, but everyone else from all over the country, which is fantastic.
Yes, yes.
It's
So let me
testament to
see.
the
Who
hard work
wants
that Norma does.
Thank you. Anyone want to raise their hand? Do they have a particular question to start with?
Yeah, the floor is yours.
Okay, Daryl.
Oh, sorry.
Oh, sorry.
Let,
Did you call on someone? I couldn't hear.
I saw
I'll try.
Daryl's hand, I think, go up first.
Okay.
Well, plenty of time for everyone's questions.
Daryl, you have a question?
Yes, I'm wondering, I'm not 100% sure. My wife has Lewy body. She definitely has Alzheimer's or has dementia, I guess. And I understand that you can have both. How important is it that I get a diagnosis of that? And what is the test for that? I understand there's a specific test that you can have done.
This is a very, very good question, very common question. So I would say it's extremely important to get the correct diagnosis. So let me kind of backtrack some terminology. I think this might help a lot of people. So the term dementia is just a symptom, implying some form of cognitive impairment. Most people assume that cognitive impairment means memory impairment, although it could be any facet of your cognition. It could be your visuospatial skills, executive functioning. It could be short-term memory, long-term memory, recall, a host of factors. So dementia is just the symptom. It's not the disease. There are plenty of causes of dementia, Alzheimer's being the most common, Lewy body being the second most common. But there are a host of other causes of dementia, whether it's stroke, multiple sclerosis, Huntington's, brain tumors, concussions. So you have a lot of potential causes of the dementia, and the treatment and the nuances vary condition to condition, right? So if you take two different people with the same exact symptoms, they could still have very different diseases, and the way we approach them is very different. So the importance of the diagnosis is very helpful because I need to know how to treat you, and without the right diagnosis, we're just throwing darts, but there's no dartboard. And so it's really important to kind of hone down as much as we can the actual diagnosis. The diagnosis is sometimes challenging. It's not as clear cut as just doing a simple blood test and there you go, here's your diagnosis. It's about doing a lot of different tests to kind of rule out certain conditions and rule in potentially Lewy body. Now, you're allowed to have more than one condition, right? So it is possible that somebody has both Lewy body and Alzheimer's, or Lewy body and strokes, or Parkinson's and Lewy body, or Parkinson's and strokes. So there's a lot of overlap. And so there's no one test specifically that will say, aha, this is definitely Lewy body. And everyone kind of approaches it a little bit differently, and there's a lot of tests that are available to us. The test that I find very helpful that kind of can help in differentiating the different types of dementia, for one, is a formal memory test. It's called a neuropsychological evaluation. A lot of times that can really pinpoint the types of cognitive symptoms that somebody's having, and the symptoms that somebody has in Alzheimer's are often very different than those in Lewy body. So that alone will kind of help us initially. There are tests that we can do that look for certain changes in the brain that we are more commonly see in Lewy body, such as a DAT scan, a skin biopsy, and even something called a lumbar puncture, where we take fluid out from the lower back and analyze it. And those are similar to tests that we do for Alzheimer's, which are a PET scan, a lumbar puncture, and some blood work. And so usually when I see somebody with Lewy body, unless they've already had the testing done before they see me, I do all these tests to see if we're dealing with Lewy body alone, Lewy body and Alzheimer's, or not even Lewy body at all. And then, like I said, the treatment is very, very different. We have a lot of treatments for Alzheimer's that don't work in Lewy body, that might be actually unsafe in Lewy body. There are certain medications that we tend to avoid in Lewy body, but are actually relatively safe in Alzheimer's. So that distinction is very, very important in terms of the treatments, in terms of clinical trials, in terms of understanding what to expect with the symptoms. So whereas back in the day, we used to say, okay, well, somebody has dementia, it really doesn't matter what's causing it because we don't really have a clear treatment or a change of course of action. Nowadays we do. So it is very, very important to kind of make sure you hone down the right diagnosis.
Thank you. Thank you, Daryl, for the question. Who has the next question? Travis? You're on mute, Travis.
I think you're still muted, Travis.
Okay, there you
Can
go.
you hear me now?
Yep.
Yes.
I was trying to keep up. I'm slow at taking notes, and I think you said formal memory test.
Correct. It's called neuropsychological evaluation. It's like a 3 to 4 hour test where they look at every single facet of your cognition to determine where the problems are.
Okay.
You can, yeah, you can write neuropsych test, shorten it a little bit.
Yeah.
That'll be helpful. Thank you for the question, Travis. I know that's important. Thank you. Who had a question next? Barb and George?
Yeah, hi, this is George.
Hi.
So I don't have a formal diagnosis yet, but we believe I'm on the path to getting a Lewy body. I have had a neuropsych eval, but I haven't had any of the other physical tests. And I'm joining Medicare in August, so my insurance will start giving me some options because my current insurance doesn't allow those physical tests. So my question really is, I would need to travel to a center of excellence, or should I travel to a center of excellence and get an expert in the Lewy body realm and start following up? Because my current neurologist is really a movement disorder specialist. And so far, she's kind of just a wait and see and waiting for her symptoms to get worse. And it's kind of frustrating.
So
and if I do travel, what is the best approach to getting seen?
George, can you just remind where are you again?
I'm in Wisconsin, so our closest would be Mayo in Rochester or Rush in Chicago.
I think Dr. Meytin can answer your question though.
Yeah. So a couple of things. So one is you mentioned some of the tests weren't covered. Usually they are covered, even with private insurance and Medicare. It depends on how you document and what you submit to the insurance companies, but usually we can get the majority of these tests approved. I've really never had an issue kind of getting them approved. Some a little bit harder than others, but with enough description and appeals, you can get them all covered. It just depends on kind of which one, and there are some nuances to it, but they're almost always covered. A movement disorder neurologist usually is the person to see for Lewy body dementia or any kind of dementia, really, or a cognitive neurologist. Now, it's possible that the one that you see just doesn't have enough experience with Lewy body or enough knowledge of it, but most movement neurologists are who manage Lewy body dementia specifically. So I don't know who your specific, movement neurologist is and their background and history. But certainly if you're not getting the right answers from this person, regardless of who they are, seeking a second opinion sooner than later is important. Rush has a very good movement disorder center. The Mayo Clinic is usually fantastic. They're just usually a little bit tougher to get into. Usually I find that people go to the Mayo Clinic for kind of undiagnosed conditions or if they don't have a local movement neurologist. They're generally not, and I may be wrong with this, but usually they don't see patients on a regular basis. It's more of a kind of consultant type thing that they do. But Rush has a fantastic movement disorder center. So if that's close to you, that's who I would see, especially if it's a department. If it's just an individual neurologist that's in a local community, they might just not have the resources because a lot of times we work with neuropsychologists and psychiatrists and therapists and other people in our area that specifically have focus on Lewy body. But the sooner you can get that done, the sooner they can realize, is this what's going on or not? Like I said, all those tests really should be covered without problem. Well, most of those tests should be covered without issue, whether it's Medicare or not.
And thank you so much for that. George, I just want to tell you, if you are near Rush, we just had recently, less than 2 weeks ago, Jory, Jori, Dr. Jory Fleischer was on here speaking, and she's part of doing a trial for people with Lewy body. She's at Rush. She's an expert in the disease. So I would highly recommend if you're able to see her. Her name is Dr. Jory Fleischer.
Can I just ask a follow-up question to that?
Yes, of course.
We had asked for the skin biopsy testing, and at UW-Madison, our neurologist said, well, I'd have to send you to Appleton, Wisconsin for that, and it probably wouldn't be covered. And she said it would be positive regardless because she is convinced he has a Parkinsonian type illness. All he's had primarily are cognitive issues so far. And she said it doesn't matter, that skin biopsy doesn't matter because it would be positive. And is that kind of an opinion that is widespread?
So sort of, if there's clear signs of Parkinson's on exam, then yes, you don't necessarily need that test to add to it because that test is going to be positive with Parkinson's and Lewy body. So that test wouldn't be helpful if somebody already has Parkinson's symptoms. So that part I do agree with. If somebody detects on exam Parkinson's symptoms, the utility of the skin biopsy, it's not going to really add much to it. And then some of the other tests, namely the PET scans and the Alzheimer's tests and the neuropsych testing, those are the ones that kind of can help definitively tell us. The skin biopsy is helpful if you just have cognitive symptoms but no physical symptoms where we're not sure if there's a Parkinson's or not, then it's helpful. But the skin biopsy looks for this abnormal protein called alpha-synuclein, which we see in Lewy body, in Parkinson's, and in something called multiple systems atrophy. So that biopsy does not definitively tell us which one it is. Also with Lewy body, there all are potentially false negatives. So a normal test doesn't mean that you definitely don't have it. This is a condition where you got to look at everything together. It's not just one test that says, aha, you definitely have Lewy body, here you go. You got to kind of piece it together. And even if you look at the criteria that we have, the best that we can actually say without an autopsy, an autopsy we're not going to do on somebody who's alive. So without an autopsy, the best that we can actually say is probably Lewy body based on the criteria. Because These are just kind of surrogates for guessing what's happening with the brain tissue. On top of that, like I said, you could have both. So somebody, and we found this in studies where we look at the diagnosis given before death and the diagnosis whenever somebody passes away, we've seen changes of both Alzheimer's and Lewy bodies sometimes. So you are allowed to have both. So it's a kind of a fluid process, and it's not always as easy as the textbooks kind of make it out to seem, where it's, like I said, it's an easy, here's a blood test, you have Lewy body, nothing else, you're good to go. So it's, you really need somebody who kind of understands the nuances and kind of look through everything and say, I think most likely you have Lewy body, but there's also maybe a small component of X, Y, and Z going on.
Thank you.
Jean, you have a question.
Yes, I have a different opinions with two doctors. One says he can take gabapentin for pain, and the other doctor says it is controversial with Lewy body.
So generally speaking, obviously I don't know, the history here, but generally gabapentin is a pretty mild medication. I do routinely use that for pain and for restless leg in my Lewy body patients, with the exception of those individuals who have really bad kidneys, because then you can't filter the medication very well. But otherwise, yes, generally speaking, we can absolutely take it. And one of the most important things I think that's important to know with Lewy body is it's rare that we say you absolutely cannot do something. And this is probably the case with medicine in general. It's a risk-reward discussion or risk-benefit analysis. If somebody is having pain, pain itself can induce hallucinations, right? So we have to treat it somehow. Some meds are better than others. Gabapentin is much better than the opioid medications. But even then, we sometimes do use opioid medication because somebody's having pain. So, with the exception of a few medications, most things are up for interpretation depending on what symptom is in front of us, what are the potential risks, and what are the potential benefits. We've got to look at the whole individual case. But generally speaking, I have no objections to gabapentin.
Thank you.
Thank you. Thank you, Jean. Jean B has a question.
Yes. My husband was diagnosed with mild cognitive impairment in 2018. He subsequently developed a tremor in his right hand and terrible problems with balance. We're now in 2025. A movement disorder specialist at University Hospitals in Cleveland diagnosed him with Lewy body, and I believe that he's in the late stages now, and we've got him on hospice, so we have virtually no medical care except a nurse coming a couple of times a week. I don't know if I'm doing the right thing. Maybe you could just discuss late stages, please.
So is the movement neurologist that you see not involved in the care at all, or is just the nurse, or?
Now that we're on hospice, he'll get kicked off hospice if we go to the movement disorder specialist.
So sort of. So there are ways around that. So usually I stay involved through the very end. We just can't be the primary neurologist and we can't necessarily do full visits. But the treating physician who's part of the hospice team can and should reach out to the movement neurologist with questions. That is perfectly okay. If you have access to a MyChart portal system or a similar system where you can kind of ask your neurologist questions, you can still ask them questions. They can kind of make general recommendations. I believe there are also ways you can kind of pay out of pocket to see somebody separately. So there are ways. A lot of it just comes down to the insurance restrictions because they say that if you're on hospice and there's only a few months to live, you're not going to necessarily need acute care. But the nuances of what medications to take, what might be helpful, that is still very helpful to have a movement neurologist or a cognitive neurologist, or at the very least a psychiatrist to kind of run things by, just to make sure that the goals of care are being met within this condition, which is very different than end of life for cancer, for strokes, for other things. Because like I said, certain medications are not ideal, whereas others are. And so I find that the hospice physicians, although they're fantastic individuals and very, very smart, they might not see enough Lewy body to really know. Now, if they have enough experience with it, you're probably okay. but there's really no harm in them reaching out and just touching base with your movement neurologist just to see if there's anything else they can think of to help.
Thank you for that. And that's so important, Jean. And so I'm just want to put in my 2 cents here. For anyone who is on hospice at home, many of the hospice agencies will give a packet to put in the refrigerator in case of pain, and it's there for any needs. Many times, even though I'm not a physician, I will speak. Dr. Meytin, I'm sure will agree. A person with Lewy body should never be given Haldol. And that packet in the refrigerator from hospice many times has Haldol in it. Please be sure that it's never given. Say he's allergic to it. So I just want to say that to you, Jean, just in case.
The physician from hospice has really been of no help whatsoever. He didn't even do a telehealth visit with my husband when we signed him up. So I'm kind of at a loss.
Jean, I want to suggest, I'm sorry, go ahead.
I was going to say, there are other hospice agencies
Exactly.
you can check out. You can also reach out to them and say, how come nobody's kind of checking in with us? Every hospice agency works differently. Maybe the nurse is supposed to be reporting to the doctor, but she's not or he's not. So it could be a miscommunication somewhere along the line. But you could always choose a different hospice company. I mean, generally, the hospice companies that I work with are systems that have movement neurologists.
Oh, yeah.
So there are definitely options
Goody.
there.
Helene, you need to be on mute. Sorry. Sorry.
So
Sorry.
it's just about kind of figuring out, like, are they the right fit for you guys? Just like a regular neurologist would be, or a primary care doctor, is this the right team for you specifically? I routinely have hospice physicians reach out to me with questions and advice and things of that nature. So that shouldn't be a barrier generally.
Thank you for that. Who has a question? Sylvia, please.
Hi. So I have a quick question. When my husband was diagnosed, they did the full cognitive, 3, 4 hour, I mean, it was really thorough, and determined he had Lewy body dementia, but they never did like the DAT scan or the skin test or anything. And I was really trying to get them to commit to doing a DAT scan and the skin test. And I asked to be referred over to a neurologist he was at UC Davis in Northern California. And I said, I'd like to get a second opinion at UC San Francisco, UCSF, which is renowned for a lot of stuff. And he said, yeah, I understand why you don't need to get a test. Your husband shows all the other symptoms, and just by those symptoms and the cognitive test, we know that he has Lewy body because he had the loss of smell years before. He was having hallucinations. He has the REM sleep issues. And so with all that and the dementia, they said there wasn't a need for a test, and I have not been able to get one. Do you agree with that? I mean, is it pretty clear that he just has those symptoms, so he must have Lewy body?
So yes and no. I mean, it's hard to say because I don't know the specifics, but you don't always need the additional testing. Uh, and the testing does have false negative rates. So if the cognitive testing shows changes that are consistent with Lewy body, and there are other core clinical features of Lewy body, then generally we don't need the testing, just because there's no additional information we'll glean from it. So it just depends on how certain the testing was and what his exam is like. It's particularly with the DAT scan, only a subset of patients will actually have a positive scan. So that in of itself doesn't necessarily mean anything. And a skin biopsy, although it's relatively benign, is still taking off pieces of skin off somebody. So it has to be weighed with, are we doing any potential harm? And what are we going to gain from that information? So if somebody's already more or less certain about the diagnosis, some of those tests may not help. now the other question is, are there potentially multiple things going on? And so sometimes we do the Alzheimer's testing to also make sure, does somebody have Lewy body and Alzheimer's potentially, but that will usually be picked up on the cognitive testing if done by somebody who is experienced in it. That being said, there's no harm necessarily in doing some of these tests, but it's not always necessary.
And I have a follow-up question, and this may be a Norma question. On the care team, clearly he's got his primary care specialist and he's got his neurologist. We should definitely, I think, we used to have a psychiatrist and somehow it dropped off. Is a psychiatrist an important part of the team? And what other specialties should we be looking at?
So it depends on the individual. If somebody has a lot of psychiatric issues that are above and beyond what the movement neurologist can handle, then it's probably helpful. The problem is most psychiatrists don't really know that much about Lewy body, so you have to find somebody who has some expertise in it, or at least somebody who has expertise in cognitive disorders. It's hit or miss if it's helpful or not, honestly. I mean, most psychiatrists defer to me for the psychiatric symptoms. We are fortunate that we have a neuropsychiatrist who actually used to be at UCSF. And so he's a movement disorder neuropsychiatrist. So he's there if I need him. So I have that advantage. I can always refer to him. It's not always the case that I need him, but it does pop up where the psychiatric symptoms are a little bit more complicated than I can handle. A regular psychiatrist may not be the most helpful. It just depends. It really depends on your movement neurologist. Are they comfortable managing the symptoms? Would they be willing to coordinate with a psychiatrist, even if they don't necessarily know that much about Lewy body? Are they open to coordinating with their team? So it just kind of depends on what you feel is comfortable for you. Certainly having a social worker is important for either the therapy, but also for resource management. Every city, every state is different with the resource you have available to you, whether it's home health aides, whether it's home modifications, whether it's respite care for you as a caretaker, whether it's mobility devices, whether it's financial assistance. So, and most movement centers have that available if needed. So that aspect is very, very important. Having a physical therapist or a rehab team to make sure the physical symptoms don't get worse is helpful in the right situation if available to you. Having a good primary care doctor is also very important because just because there's Lewy body disease doesn't mean that you're not going to have other medical problems. And so doing the regular checkups and making sure that the rest of your body is taken care of is just as important. And will they also coordinate with your movement neurologist to say, okay, this is going on. I know it's not Lewy body related, but I'm not sure which medications I can use safely. What do you think? So that part is very important as well.
I only have one thing. That was perfect, of course. I only have one. There's one thing I would add, only for people who are about 75 or over, that a geriatrician really should be your primary. And so if your husband is younger, that wouldn't apply, but I just wanted to say that for those who may be. Thank you for that question.
A lot of geriatricians also deal with memory issues separately from the Lewy body, so they're a little bit more experienced than a regular internist. And sometimes they'll be the primary one managing patients because they know the interaction with the meds as you get a little bit older. And with Lewy body, and they're not Lewy body experts, but they certainly are a little bit more knowledgeable about drug-drug interactions, memory conditions. There may be more resources. So yes, I agree. Having, if you can, a good geriatrician is very helpful.
Nutrition.
Yeah. Chris Ann.
Thank you. I wanted to add on to a couple of things. Somebody was asking about Chicago or Rush University or Mayo Clinic. And I have connections with both. I'm seen at Mayo Clinic, and I know Jory Fleischer, and I love her. I really don't think you can go wrong. I think being involved in a clinical trial several clinical trials has been really helpful for me. And if you're early in the stages, I believe the NAPS2, it's a North American prodromal synucleopathy study. The second phase is still recruiting. And I think I have found that I have gotten really good care because of that involvement. That wasn't my goal, but I certainly am glad Mayo Clinic did take me on then as a clinical patient. I wanted to add, just from my own experience, I was diagnosed 6 years ago, prodromal Lewy body, and have not actually progressed too much except in the areas of visual spatial. And so it's really important that activity and that exercise, diet, I can go through all of those things. But one of the other things I have found as a family, we all see the same psychologist, sometimes together and oftentimes independently, because this disease is a journey. It's difficult for us and our loved ones. And so having that support has been so incredibly helpful for all of us. And that's really all I had to. I just wanted to talk. I didn't want to answer a question. So there you go. I asked a question. So there you go.
Thank you. What you said, I'm sure is helpful to many to hear. So thank you for that, Chrisanne. Okay, let's see. Who else who has a question? Someone who didn't ask yet? Okay. Hillary. I think you did ask, and then we'll go to Daryl.
Am I okay now? Okay.
No, you're not. I think you have your phone on as well.
There's a lot of echo.
I don't have a phone on.
Yeah, no, there's something.
Something's echoing.
Okay, now it's okay, I think.
It's a little bit of echo. You can also type your question if there's a lot of echo too.
Yes.
I'm sorry.
Okay, Hillary, try to write your question, okay? Because it's still doing it.
Yeah, there's a
please.
lot of echo back and forth. So you
Yeah,
just type it
and
out in the chat.
If you can put it in the chat, in the meantime, I'll go to Daryl. Thanks, Hillary. Daryl, yes.
Yes, I am still confused in a sense because I don't know. The neurologist I'm working with doesn't seem too anxious to do any more testing. He just says he did a blood test and said, yes, she definitely has dementia. But with the signs I'm seeing, it seems like she has Lewy body, possibly Parkinson's, because she has the tremors and she's hallucinations. So my question would be, you say the treatment might be different depending on how she's diagnosed. There's no cure for it. So I don't understand what kind of treatment that they would get that would be different than what she's getting now.
That's a very good question. So if it's Alzheimer's, we actually have several medications now that have been approved in the last couple of years, specifically for Alzheimer's.
She's not a candidate for those because she has a small brain aneurysm, and those possibly cause bleeding, so she can't do that.
Yeah. So, but I'm speaking kind of in general terms. So, there are specific treatments for Alzheimer's that exist now. There are also a lot of nuances to medications you can and cannot take, specifically with Lewy body, versus they are relatively safe in Alzheimer's. So, yes, there's no cure necessarily, and there's no specific drug for Lewy body that's necessarily going to slow down the progression, but how we manage it, the symptoms, kind of the medications we use for the same exact symptom in Alzheimer's versus Lewy body are very different. For example, agitation is a common symptom of both Lewy body and Alzheimer's. There are medications we use in Alzheimer's that are perfectly safe, but those same medications really should not be used in Lewy body. Haldol is a perfect example. That's much stronger. Most people don't use that anymore for either condition, but theoretically, it's not that unsafe in Alzheimer's, but in Lewy body, it's very problematic. So it's just knowing the condition and medications you can and cannot use. It's if medications come out on the market that are specific to one condition or the other. And like I said, you could have both. So there's no blood test for dementia. There is a blood test for Alzheimer's, but there could be Alzheimer's and Parkinson's, Alzheimer's and Lewy body. So kind of knowing the differences and the medications that are safe to use is the main reason in this case to potentially get that differentiating diagnosis.
Thank you.
You're welcome.
Who else has a question? Okay, Hillary, I'll take Hillary. My husband had bad side effects to donazepam. Has incontinence due to prostate cancer. Seemed worse, very dizzy. What about the rivastigmine patch?
So very good question. So I do find that the patch tends to have less side effects than the pills. So it's very reasonable to try the patch to see. Urinary symptoms can happen with both though. So it's possible that the same side effect will occur, but because it's a very different delivery system, it's possible that there will be no side effects. So it's worthwhile to try that to see. There's also a medication called Meytin or Namenda that has some potential benefit as well. And sometimes even if there are side effects to the medication we use like donepezil or rivastigmine, if the side effect is potentially manageable with another medication and the donepezil is helping the cognitive symptoms, it might be a trade-off we're willing to take. So that's where the discussion of risks and benefits comes in, because we are somewhat limited with the cognitive drugs. So if incontinence could be managed with a Depends or other medications, but the medication is helping the cognition, it might be a worthwhile trade-off to do. But at least I would start with some of the other options first, like the patch or the Meytin before redoing the oral donepezil.
Thank you for that, Daryl. I hope that clears it up a little. I know it can be very confusing. And I also would suggest, if you're not getting the proper answers, to please try to find a movement disorder neurologist in a well-respected medical center in your community to find a second opinion. Okay, somebody else said something in the chat. Let me just see. Oh, Hillary said thank you. Okay. Who else has a question? Yes, Travis. Please unmute.
Sorry about that.
No, that's okay.
Let's see.
We have two questions.
Yeah, my wife Katie's here. We have two questions. One is about I was going to do that one first.
Okay.
Yeah, carbidopa. It seems like I've heard at some point that it loses effectiveness over time. Is that true?
So yes and no. It's more so that the disease progresses. So your doses are going to change and your requirement for doses is going to change rather than it loses its efficacy. So if the disease was stagnant, sorry, if I don't move enough,
It's okay.
and my lights go off. So if in theory the disease was stagnant, which it's not, unfortunately, but let's say it was, Lewy body was like a stroke where once the damage is done, it stays the same, then the carbidopa levodopa would always work the same. But because both Parkinson's and Lewy body are naturally progressive disorders, and there's a lot of nuances with kind of side effects and other symptoms that develop, your dose of levodopa always has to be adjusted. Sometimes higher, sometimes lower, sometimes it's a different formulation of levodopa. So there's a lot of ways we can adjust that. It's not as simple as just increasing or decreasing it, but it's always an evolving process. First of all, do we even need it at all? And second of all, what are we really trying to treat with the medication and how do we do that?
Thank you. And Travis, you had a second question?
Yeah, it's about rivastigmine. He's on the 13.2 0.3 milligram patch, and it's been really helpful. It's worked really well. And the thing that I haven't been able to get an answer to is like, what does the future look like with rivastigmine? It might be similar to what you were just saying for carbidopa, but is this a drug that is, from our perspective, living with this, is it going to get less effective over time? Or what? Like, what does the future with this drug look like?
Because our doctor said the 13.3 is as high as it goes.
Yeah, so that is as high as it goes. And it's similar to the carbidopa levodopa in the sense that, yes, things are progressive. So there might be a time where your effect to the medication or your response to the medication isn't what it is today. When that will happen, no one knows. If that will happen, no one knows. But yes, it is the highest dose that we have, at least at this point. So there's no way to increase it necessarily. And there's no way to kind of anticipate what's going to change. But like I said, if you're not taking the memantine or the Namenda, there's some evidence it could help. And so depending on what's going on, that is there for possible improvement.
And then, trying to think what I was going to ask. Sorry, I'm drawing a blank on it.
No, that's okay. You
Okay.
had those. If you think about it, I'll move to someone else and you'll still have time to ask.
Okay.
I'll go, Steve, Dr. Meytin, Steve has a message in the chat. His mother is on hospice with end-stage Lewy body, currently on low doses of quetiapine, or for those who don't know, Seroquel for daily agitation. It is effective, but also causes sedation. Would you have any other recommendations for medication?
So, I mean, quetiapine is a pretty good drug. Yes, its biggest side effect is sedation. One of the biggest symptoms of Lewy body is also sedation. Most of the medications we use for hallucinations can cause sedation. It kind of just depends on how high the dose is and how bad the sedation is and when it's being given and for what purpose, because it's used for hallucinations, for agitation, so it has different purposes. So it's just kind of working with your neurologist to either adjust the medication, sometimes splitting up the dose. So if you're taking even a low dose, if you split it in half and then space it out a little bit, that could help. The timing of the medications could be helpful. Because we have somewhat limited options for hallucinations in Lewy body. The other medication that is oftentimes used is called clozapine. But that oftentimes requires blood draws on a regular basis, either every week, every other week, and then eventually monthly. There is another medication called Nuplazid or pimavanserin, which is not technically FDA approved for Lewy body dementia. It's approved for hallucinations in Parkinson's disease, but I've used it pretty regularly in Lewy body with a lot of success, and that tends to be less sedating, but not as strong as quetiapine, and not as quick in terms of its results. So it just kind of depends on the specific situation. There are drugs available that are out there. It just depends on what's going on specifically.
Thank you. I hope that helps answer. Helen?
My question is because if this is my sister that has Lewy body, I'm one of 8 children. My siblings and I, as well as some of my nieces and nephews, are wondering, is there a test or something we can get to find out if we might also have it?
No. So there's no way to test, nor is there really a reason to test unaffected individuals. Generally speaking, Lewy body dementia is not hereditary. If this was somebody who had it maybe in their 40s and 50s, I can maybe make a different argument because it's a young onset. But when it comes on in kind of normal time frame, 60s, 70s, 80s, the risk to family is very, very slightly higher than the average population. So even if there was a test for it, I would recommend against it because there's a much, much higher chance of you not getting it and just worrying about it than you getting it. If it happens, it happens. It's a very common condition, but I wouldn't say that there's anything different you guys have to do, with the exception of exercising. Because now that it's in the family, it's a slightly higher risk of getting it, But like I said, it's generally low risk, but exercise has been shown to prevent the progression of and the onset of some of these conditions. So if nothing else, it could be kind of a wake-up call and say, okay, we got to get exercising so that our risk is less than the average population.
Great. Thank you.
You're welcome.
Okay, who else has a question? Comment, anything? Terry, my husband has Parkinson's. He was using Exelon patches, mid-dose. Okay, Terry, do you want to, let's see what you're saying. His neurologist changed him to diazepam and memantine. His afternoon agitation and anger has worsened. Why is Exelon the only med in the class approved by PD?
For Parkinson's.
Okay.
For Parkinson's.
And her husband also has bipolar disorder.
So there's a lot to unravel there.
Uh,
There's a lot of questions, and it's not a simple answer. Let me get to the first one. So, because it sounds like there's Parkinson's, Alzheimer's, and bipolar. So, I mean, there's a lot of symptoms going on there, and a lot of conditions that could be causing the symptoms. So, it's not going to be a straightforward answer. Exelon and Aricept and Memantine are both used for cognitive impairment, whether it's Parkinson's, Alzheimer's, or Lewy body. So that will help in all three conditions. So all three can work and are approved and do get used in Parkinson's disease, dementia, Lewy body disease, and Alzheimer's. Neither of them should cause agitation. That's probably the underlying condition itself, but anything is possible. So if there's a medication that started and there's a new symptom that develops after starting that medication, then usually I tell people to stop the medication. Certainly, bipolar disorder itself, if not completely treated, can cause agitation and even some cognitive issues. So I think this is something where you really have to sit down with your movement neurologist, possibly even the psychiatrist, and kind of really get down to the bottom of what's really driving the symptoms and what is the goal of treating each individual symptom.
Thank you.
You're welcome. I'm not sure if Helen has a question. The hand is raised, but I'm not sure if that's from the previous question.
And let's see, anybody else? We have just a couple of more minutes. Yes, Lee and Paul.
So I'm not sure if this is too specific, but I'm hoping to keep it more general. And you talked about adjusting medication. And in an ideal world, it sounds very clear that you're working with your doctor as your situation evolves. But in the real world, we see the doctor once a year, maybe twice a year. And my father is living with Lewy body. His activity level has changed significantly. So what we need from the medication changes. Maybe with Louis, you're on the roller coaster. For 3 months, he hasn't been doing much activity. So are we getting the benefit from the carbidopa, or is it causing more dizziness that we'd like to decrease while we're at home? And so I'm not entirely sure how to best frame the question, but a little open-ended as we're communicating on my chart and trying to give someone the picture. Who is the best point person to help us with sort of the not daily roller coaster, not acute situations, but we don't go out to ping pong for Parkinson's anymore. So is it possible that our carbidopa levodopa dosage is causing the increased dizziness? Is it worth trying less? Is that something that we can safely try at home? Is it worth trying to book an appointment? Just what is the general guidelines in real life with limited access for support in making some of those decisions and best practice?
So, yeah, I mean, I think seeing your neurologist once or twice a year is probably insufficient unless things are going smoothly. I can't speak to whoever you're seeing in their practice, but, the appointment times, sorry. The appointment times are placeholders. So if everything is going well, yes, see me in 3 months, 6 months, whatever that may be. But if things are not going well, then you need a sooner appointment. If it's a quick, my chart is meant for kind of a quick question. It's hard to kind of unravel a lot of the specifics of Lewy body just with a quick my chart message. Yes, we can put out fires that way, but ultimately it probably needs a full appointment, probably much sooner. For my patients that are doing a little bit worse, I see them more frequently, just so we have that kind of set in stone that we'll see each other every 2 to 3 months. If I hear something from the my chart message, I think this doesn't sound right, we need an appointment, we schedule an appointment. It might not be that same day, but we try to get it sooner than later, because it is an evolving process. And what works now might not work in 3 months. So, some of it is, yes, the more you are able to kind of, concisely provide to your neurologist, the better. But you are not a physician. I don't know. But so that's your role, is to be the family, and it's the physician's role to kind of establish what and when has to be changed. And so it might not be something you see them every week, but at least there's a game plan of, okay, if this and this happens, what should I do? So it just depends on the practice, on who you're seeing, how often you're seeing them. There's certainly a shortage of movement neurologists. There's a shortage of neurologists, shortage of everyone, unfortunately. So some of that is just not going to be possible. But the more that is, the better. The more availability you have, the more you're able to at least communicate with them, whether it's through my chart, through the phone, the better. So I know that's kind of a vague answer. But because Lewy body is a roller coaster in a lot of ways, you have to. It's a flexible process. It's not you have a cold. Here's your antibiotics. See you in a year for your physical. That's not really how this works. Unless somebody is super stable, then yes, we could do that. But once again, that's still a placeholder. And if something changes tomorrow, you need to be seen sooner.
Okay,
That
thank
helps.
you. We really don't have any more time, much more time. I just wanted, if it's okay, to answer one more question from Travis, who had written a few minutes ago. He said some nights the symptoms of twitching get noticeably worse. He's on carbidopa and Nuplacid that is supposed to help. He's wondering if there's something else to address this.
So this twitching is in. What do you mean by twitching?
You're on mute, Travis.
All right. My
While
Do you
you're
mean
asleep.
inner twitching or?
while I'm especially when I'm trying to fall asleep at night, which I'm having more trouble with lately, I'll just twitch and it wakes my wife up, and then I roll over and so
Your body has, contractions of muscles that feel like a twitch and it does also happen while you are asleep.
okay.
So it kind of just depends. I mean, carbidopa nor Nuplazid would treat twitching. It could be something called periodic leg movements of sleep. It could be restless leg. It could be a muscle cramp. It's kind of hard to say. I tell people to videotape and take pictures of things so I can see it, because what you think of a twitch, I might have a better term for that has specific treatment. And so if you get more objective data of it, namely a picture or a video, I can kind of look at it and say, okay, this is what I think this is what we should do about it. Because the medications, the carbidopa, levodopa, the Nuplazid, whatever you're taking, is to treat a specific symptom. So if that symptom is not what that medication is treating, it's not going to help. So taking more of that isn't going to help. So it just depends on what's actually going on. And that's also a good discussion to have with your movement neurologist specifically.
Okay.
Okay. Thank you for the question, Travis. Dr. Meytin, thank you so much for being here. I know this has been so important and informative to many people, and I have recorded it. Many people who couldn't attend also would like me to send the recording, and we will have it on a website for anyone who didn't see it. Thank you all for attending, and if you have any more questions, please don't hesitate to email me at norma@lbdny.org. Thank you again, everyone.
And
Welcome.
if this was helpful, I'll be happy to come back and do another one. If this is helpful for individuals, just let Norma know. And she knows how to get in touch with me. So I could certainly do something like this or something similar, something different. Whatever is helpful for you guys, I'll be happy to do.
Thank you so much. That's really important to hear.
All right, you're absolutely
We
welcome.
appreciate you. Thank you.
All
Bye-bye,
right,
you
bye.
all.
Thank you.
Okay.
Bye.